Hello, this is John Flutter from Myofunctional Orthodontic Training. Welcome back to the channel. This is one of a series of short videos where I'm looking at some of the claims that Dr. Michael Mew has made, both on his website and also in his patient treatment plans, that have been examined by the British Orthodontic Society and reported to the General Dental Council on the grounds that they are false and misleading. So Dr. Michael Mew has been asked to provide evidence to support the claims that he's made, and I want to look and see what evidence there is to support the claims that he makes. One of the claims he makes is that the maxillae, when there is a malocclusion, they don't grow adequately forwards. So the tongue, which is the driving force of the maxillary position within the cranium, when it's not in the palate, it's not driving the maxillary growth forwards, and so in most malocclusions, then there will be a retrognatic maxillary arch, even when there is a increased overjet. And so the bigger the overjet actually might argue that the more retrognatic the maxillary arch, and sees a restriction in the maxillary and mandibular arch and in their position in relation to the cranium, whereby the maxilla should be further forwards. And yet most of the cephalometrics to show the positions of bones within the cranium are based around Nasion and A point, and although you can get lots of numbers from that, it doesn't really tell you how the bones are related to the rest of the cranium. The cephalometric analyses that do show that well are the archial type analysis, like the Sassouni analysis, but there are others, that compares the dentomandibular structures to the rest of the cranium. They generally show that the maxillary arch is retrognatic, and they're not widely used in orthodontics. So trying to show the movement of the maxilla and how it hasn't grown adequately forwards is very difficult using traditional cephalometrics that are based on Seller Nasion or Basion Nasion and then superimpositions. And yet we know that in mouth breathers, the mandibles and the maxillae are retrognatic. And when I see these mouth breathing children, sometimes I see them with an anterior crossbite, and sometimes I see them with an increased overjet. Now, if it's the maxilla that's set back within the cranium with a reduced airway and reduced pharyngeal airway, the relationship between the mandible and the maxilla, in my view and in Dr. Mew's view, isn't as important as the relationship between the maxillary arches and the cranium itself. So if there's an anterior overjet, it just means that the maxilla's a long way back. If there's an increased overjet, the maxilla is still back, but the mandible's back even further. So Nasion and A point do not represent good reference points when we're trying to determine where the maxilla is within the cranial bones. But if we look at the cranium, we can get a much better idea. We can see the two maxillae, we can see the cranial bones, we know what ideal anatomy is, with the maxilla much closer to the frontal bone than it appears in this girl here. And when I look at the other faces, when I look at these twins, identical twins, I can see clearly there's a different relationship between Nasion and the frontal bone. So using Nasion as a reference point to tell you where the maxilla is likely to be inaccurate in terms of a reference point. And the other claim that Dr. Mew makes is when the maxilla is set back, it will have an effect on the pharyngeal airway. And when the maxillofacial surgeons look at cephalometrics and decide on whether maxillary advancement surgery is appropriate, they look at the pharyngeal airway, and if they see that's inadequate, that's one of the indications for them that the maxilla is retrognatic and needs to be replaced. And we can't distinguish the position of the maxilla from the transverse development of the maxilla. When we've got crowded teeth, we'll have an underdeveloped maxilla, and then the nasal passages will be restricted in addition to the pharyngeal airway. Now this young lady, she was classified as class 3, large mandible, but when I look at the view from underneath and I see that the maxilla is set back a long way from the frontal bone, one of the purposes of the maxillae is to support the eyes, and particularly on a right eye you can see very little support for the orbit and the eye itself. And that stick is placed between the canines and the first premolar, and it shows the rotation of the maxilla and the underdevelopment of the right maxilla, which is more underdeveloped than the left maxilla. I can see that in the face, and I can see that by looking at the upper dental arch. But I haven't got a number that can measure that. I can see it, I can record it, but I can't measure it. And the more distorted the bones of the cranium are, the more distorted the maxillae and the temporal bones are. So it's going to have an effect on the relationship between the mandible and the two temporal bones. In particular, the way that the temporomandibular joint grows and develops, the relationship between the head of the condyle and the glenoid fossa is based on the position that the mandible is usually held. The growth and development of those temporomandibular joints are taking place with a mouth open posture, which we're going to conclude is less than ideal. So when it comes to evidence, the lowest form of evidence in the hierarchy of evidence is individual patient cases. So I can show patients I've treated in the past and I've helped to establish nasal breathing and improve tongue posture, but I'm told that the changes would have occurred anyway with natural growth. And even though people are using these techniques worldwide, this is a series of cases that was published in a Japanese journal by some orthodontists in a university, and they take measurements and they take cephalometrics of changes that take place when they train the tongue in the palate, but again very low levels in the hierarchy of evidence. Even though people throughout the world can make improvements once the tongue posture has changed, it's very difficult to prove cause and effect. It's also very difficult to help children to improve their tongue posture. It's all very well saying improving tongue posture does improve cranial growth. The techniques required to help children do that are not considerable, but in my view, not insurmountable. And so the question of the evidence to show that the maxillae is largely retracted is difficult to find in what I've shown you so far. What we're going to look at in the next video is about this, more into this three-dimensional collapse of the maxilla, and look at some of the scientific evidence in the standard text that could explain why tongue position could and probably is an important factor in the positioning of the maxillary arch within the cranium. So if you've enjoyed this channel, please give us a thumbs up and subscribe to the channel, and look forward to seeing you in the next video next time.